Good morning and welcome to the North Dallas Chamber of Commerce Healthcare Conference. I'm Jennifer Chandler, Bank of America Market President. Bank of America is pleased to be a gold sponsor once again this year. As we all sat together in person last year, I know none of us could have predicted what would follow the following 12 months. As government and healthcare officials fight the coronavirus, they have the full support of Bank of America. I'd like to take just a moment to talk about how we're supporting healthcare and the health of our communities. In 2020, we made a $1 billion commitment over 4 years to help advance racial equality and economic opportunity, with a focus on health and healthcare, jobs and reskilling, support of small business and housing, and all with a lens of racial equality. As it relates to healthcare, we're focused on immediate healthcare and testing needs and long-term determinants of health, like addressing food insecurity. We've also made a $100 million commitment specifically to the coronavirus relief, and we've funded $350,000 of that already right here in Dallas with Parkland Hospital for community-based testing. We've also provided $650,000 locally to help address food insecurity. As it relates to PPE, we've distributed 19 million masks and 13,000 cases of sanitizer. And I'm pleased to say that work in Dallas and grew across the globe. Here locally, we supported PPE with United Way of Metropolitan Dallas and United Way of Tarrant County. We're also very pleased to announce that we're launching a program with CVS for no-cost vouchers for flu vaccinations. We're working with communities with Black African American, Hispanic Latino, and Native American populations to make sure we're partnering with nonprofits to support those communities. That will start in 7 major cities, and I'm so pleased to say that Dallas is one of those first cities to start. We've also issued a $1 billion corporate social bond, the first of its kind as a U.S. commercial bank. This will benefit nonprofit hospitals, skilled nursing facilities, and manufacturers of healthcare equipment and supplies. Those are just a few examples of Bank of America's commitment to our community and our health. And again, we're so pleased to be a gold sponsor, and there are many others. So I'd like to recognize the other sponsors this morning. Again, Bank of America, Baylor Scott and White Health, BKD CPAs and Advisors, Blue Cross Blue Shield of Texas, Children's Health, HDR, J.E. Dunn Construction, Medical City Children's Hospital, Methodist Hospital for Surgery, Holosinelli, Texas Scottish Rite Hospital for Children, and our silver sponsors, Parker University, our media sponsor, Dallas Business Journal, and supporting sponsors, Dallas Fort Worth Hospital Council, Healthy Industry Council Foundation, Team Logic IT, and the Chrisman Company. Again, we're so pleased to be here to welcome you this morning virtually. And I'd now like to welcome to the stage Dr. Mark Neve, Executive Vice President, Institutional Advancement, Marketing Communication, and External Affairs, UT Southwestern Medical Center, to introduce our keynote speaker.
Thank you so much, Jennifer. Good morning, everyone. It's just fantastic to be with you this morning. And this is my 4th conference, and I have to tell you, this is always one of the best conferences in the city regarding healthcare, and that has a lot to do with all of you, the diversity of this community in terms of, what we all together provide for the city of Dallas and for the county. So it's just really a pleasure to be here. So again, good morning. I'm Dr. Mark Neve, Executive Vice President of Institutional Advancement here at UT Southwestern Medical Center. I'm also a member of the North Dallas Chamber Board of Directors and just pleased to welcome you to today's event. As you can imagine, things have been very busy at UT Southwestern over the past several months. Like all area hospitals, we've been working really hard to treat patients and certainly do our part to contain the virus. Since the pandemic, UT Southwestern has provided ongoing advice and counsel and data to policymakers in the county, in the city, county, and state, certainly, and have been in great partnership, just trying to provide information, sharing where the virus is headed, where the virus has been through our prevalence study and other insights that we've been doing, such as our modeling. I hope all of you have gone to our website, and if you haven't, go to utsouthwestern.edu. You'll see a yellow ribbon there, and it gives you all of our updates, whether it's updates on the vaccine, whether it's updates on our modeling, as I suggested. Lots of information there, so I hope you'll take advantage and go to our website. And we're also pleased to participate in forums like this one, helping to educate community leaders on key healthcare issues and ways that you can have an impact in North Texas. Today's keynote is especially meaningful to me as someone who has spent much of my career focused on access to healthcare for the underserved. As you may already know, the Commonwealth Fund is a private foundation established in 1918, a little over 100 years ago, that at the time had a broad mission to enhance the common good. Today it is more specifically focused on promoting a high-performing healthcare system that achieves better access, improved quality, and greater efficiency, particularly for society's most vulnerable, including low-income people, the uninsured, and people of color. The Commonwealth Fund works towards this goal by supporting independent research on healthcare issues and making grants to improve healthcare practice and policy. Today, we are fortunate to welcome the Commonwealth Fund President, Dr. David Blumenthal, who has led the organization since 2013. He's been closely associated with it since the mid-1990s when he directed the task force on academic health centers. A practicing primary care physician with undergraduate, medical, and a public policy degree from Harvard University, 3 degrees from Harvard, I think we call that Preparation H. Dr. Blumenthal was the Sam Thier Professor of Medicine at Harvard Medical School and Chief Health Information and Innovation Officer at Partners Healthcare System in Boston prior to leading the Commonwealth Fund. As President Barack Obama's National Coordinator for Health Information Technology from 2009 to 2011, he led successful efforts to establish a secure nationwide health information system and to support the widespread, meaningful use of health IT. Earlier in his career, he served on the staff of the U.S. Senate Subcommittee on Health and Scientific Research. I was interested to read in one of his recent blogs that he believes, as I do, that in many ways the U.S. is not one country but two, divided geographically by persistent, troubling differences in people's access to affordable, high-quality health care. However, geography is not destiny, and we have the opportunities to help make changes in our own community. And in this regard, I look forward to his remarks today. Welcome, Dr. David Blumenthal.
Thank you so much, Dr. Nivett. It's a pleasure to be here, as I was saying earlier, with some of your colleagues. Those of us in the Northeast sometimes get a little bit isolated, and it's wonderful to have this opportunity to join with you all. There they are. Okay, so there are obviously a wide number of things that we could talk about at this point in our nation's history and the history of our healthcare system. I thought I would talk from personal experience and from the benefit of my research and observations of a number of modern presidencies about the current moment that we face in healthcare and what we might expect in the near term from our newly elected president. There are a couple of lessons that history provides for new presidents as they take on healthcare. And one of the first is this one. And it's counterintuitive because we are just at the moment of having seen a new president ascend to the White House. And we tend to think that the possibilities are almost limitless. But history shows, in my view, that the healthcare presidency, and I'll define that a little more clearly in a moment, the healthcare presidency really is, at best, about 6 months long. Can I have the next slide? And in this, I'm taking guidance from a famous Texan who once said the following to his staff about a week after being reelected. And what he said was, now look, I can't imitate his accent, but what he said was, now look, I've just been reelected with the overwhelming majority. And I just want to tell you that every day while I'm in office, I'm going to lose votes. I'm going to alienate somebody. The president begins to lose power fast once he's been reelected. There's a hint in that reelection as to who this was. And it's going to be something. We've got to get this legislation, he was referring to Medicare, fast. You've got to get it during my honeymoon. Well, if I was with you in person, I might ask the audience to suggest who this famous Texan was. And it was, of course, Lyndon Baines Johnson. And this was right after his truly landslide election in 1964 after having succeeded the assassinated John F. Kennedy. He had a very big agenda, but as a creature of the Senate and as a student of the United States government, he knew well the limits of presidential power. And when it comes to healthcare, the reason why he had to act quickly, and all presidents who want to do big things in healthcare have to act quickly, is because this issue is so politically fraught. It is so controversial. There are so many stakeholders. There is so much at stake that presidents can only take this on if they choose to, when their political capital is fully is as high as it can possibly be. It has to also happen well before, for the same reason, well before the Congress begins turning its eyes to the midterms, which happens within a year of any presidential election. So we're really talking about a very thin time. And then presidents also have inevitably other things they want to do. And for this president, President Biden, there are issues related to immigration and tax reform and climate change and infrastructure that he will want to get to, aside from healthcare. Can I have the next slide? So it follows that time is of the essence. I have the next slide. Now, Clinton did not understand this. And when he took on health reform, he delayed it. He delayed it for a number of months until after he had passed NAFTA and an economic package. And that resulted in putting him way behind the eight ball in terms of getting his health plan passed. There's another mistake he made, which I will get to in a moment. Could I have the next slide? Obama was successful in part because he had learned the lesson of Clinton's failure. And he put his healthcare ambitions front and center and sprinted as fast as he could. He almost tripped in the summer of 2009. He almost tripped, but he managed to get it under the wire just in time. There's a very complicated story about how time almost frustrated his ambitions, but he sprinted and won, learning that lesson that time is of the essence. Now, if you think about what issues may be issues of this sort, they include for Biden, and we'll talk about this in a moment, some of the items that I know you're concerned about, like making Medicaid expansion much more attractive to states that haven't expanded, or pursuing a public option. Those would both be the kinds of issues that would require could potentially require enormous amounts of political capital for a president. But whatever the president decides is his healthcare issue, if he has one, because time is so critical, the president has to arrive with a plan. In other words, waiting until you actually have taken the oath of office to begin to put your marker down on healthcare already may be a fatal mistake. That means transitions are critical. Now, I've been delighted with the amount of attention that transitions got during this past few months, because transitions are often underestimated in their importance. To some degree, Clinton's healthcare fate was sealed within a few weeks of his inauguration, at a meeting in Little Rock when a healthcare team that he had created presented a plan for healthcare reform, and he rejected it. Didn't like it, wasn't ambitious enough, wasn't exactly the right kind of plan. The result being that he had nothing when he took the oath of office and had to start from scratch, delegating it to Hillary and to Ira Magaziner. I think Biden is clearly aware of this. You can see it in the numbers of announcements he's making every day. He's a very experienced observer of the United States government and of politics. He shares a characteristic with LBJ in his deep understanding of the Senate, though I don't think there is any president in our history who has had the command of the Senate that Lyndon Baines Johnson had. But Biden has, by virtue of his actions and by virtue of where he's focused his transition time, made clear that he understands that his legacy in healthcare will be defined by the pandemic. I have the next slide. For President Biden, his healthcare legacy, and indeed the legacy of his presidency, will be defined by how he manages the pandemic. I think this is an unavoidable consequence of where we stand right now with respect to not only vaccines, but the pace and acceleration of cases and the national fear that is associated with the pandemic. And I think every day, as you listen to the news, as you read the newspapers, you see that he has grasped that and he has put it front and center. And even today, we saw the announcement of a new plan for dealing with COVID. We will be spending our time for the next several weeks and months debating the adequacy of that plan, but his awareness of its importance is crystal clear. Now, this may be Biden's one big thing in healthcare. It may be the only thing that he has the political capital and the time, once he starts turning to other issues that are important to him, that he is able to focus on with real concentration. He has put in his recovery package a few healthcare items that are devoted to expansion of coverage, more generous subsidies under the Affordable Care Act, and extension of COBRA subsidies for people who want to continue to purchase their employer-based insurance after they've lost employment. If these were enacted as part of the recovery plan, our estimates done with the Urban Institute are that he would add about 4 million people to the rolls of the insured, about reversing the loss of insurance that has occurred in the 4 years of the Trump administration. Can I have the next slide? It's clear that the public sees COVID as his clear priority. This is a poll that was published earlier this week by Morning Consult. It showed what you would expect, that large majorities of voters are interested in more assertive federal action with respect to vaccination, with respect to testing. There's even support for a nationwide mask mandate, which he will not take on, but has done what he could with through mandating masks in interstate travel and in federal facilities. There is less support. 57% of voters support restoring funds to market the Affordable Care Act's coverage options, and only 2 in 5 want any kind of comprehensive health reform passed on top of the Affordable Care Act. I have the next slide. There are avenues for action if the president decides that he wants to continue to work on healthcare. I mentioned the rescue package that he's already surfaced, the $1.9 trillion package. There will be subsequent stimulus legislation that he has labeled the recovery package, which could very well have additional healthcare components. He has the opportunity to use reconciliation, that congressional process that only requires 51 votes in the Senate, as opposed to any policy-oriented legislation that requires a 60-vote supermajority. He could, through reconciliation, do some of the things that may get jettisoned from recovery, rescue and recovery legislation, such as a much more generous Medicaid federal match that would make it more attractive to states like Texas to expand Medicaid. That expansion, that change would, I think, be permitted through reconciliation. Whether he decides to do that or not will depend a lot on how controversial it is and what his political situation at the time is and what other issues he has to deal with. One thing that I do think you will see him aggressive with, though, is executive action. Can I have the next slide, please? There are a lot of things that he can do that will expand coverage without requiring the Congress to take action. He can make open enrollment periods longer. They were cut back from 90 days to 60 days in the federal ACA marketplaces, which of course makes it harder for people to enroll. Also harder, by the way, for them to find out that they're Medicaid eligible if they go to the marketplaces looking for some kind of insurance. He can authorize special open enrollment periods in light of the public health emergency that will allow people who otherwise would have to wait for the federally scheduled open enrollment periods to enroll in the short term if they become newly eligible, for example, if they've lost employment. We know that advertising of the availability of insurance through the federal marketplaces is very important to stimulating enrollment. And we also know through work we've done at the Commonwealth Fund that when navigators are available to help people who go on the websites, that they are much more likely to successfully enroll, find a plan that works with their budget and meets their needs than if navigators are not available. The previous administration basically stopped supporting outreach and navigators. This could be done, reinstored with a presidential stroke of the pen. The president also has the option to restore the integrity of the insurance that is offered through the Affordable Care Act marketplaces through making short-term and association health plans non-compliant, as they are non-compliant with the Affordable Care Act requirements. Next slide. He can change the generosity available under current marketplace rules by linking subsidies to gold plan costs rather than silver plan costs. This would increase the amount of money available through the federal government to people purchasing all plans on the marketplace and make them more affordable. He can try to reverse some of the Medicaid waivers that have been granted to states allowing for work requirements and block granting. He could modify the public charge rule, which has discouraged many, many families, especially families of new arrivals from other countries, to seek Medicaid coverage, especially for their children. And there are a range of other actions that he could take. Go to the next slide. In the end, one thing you discover if you study presidents and their actions on healthcare is the extent to which healthcare is a personal issue for presidents. If you go back in time, you find many examples of presidents who have changed their policies as a result of their personal histories and their personal experiences. Dwight Eisenhower, it's not widely known, but toward the end of his presidency, Dwight Eisenhower actually tried to introduce a Medicare-like proposal. And the reason he did so was because his mother-in-law, who was living with him in the White House, became ill. And he became personally acquainted with the struggles that are associated with older people incurring healthcare needs and responsibilities and costs. He was eventually discouraged from doing that, but he did ask his staff to develop that proposal. John F. Kennedy became a supporter of Medicare after his father, Joseph Kennedy, had a stroke. And he commented to a number of his aides that he couldn't imagine how a family that didn't have his means could manage the problems that his father was having. And that led him to be a strong advocate of Medicare. And of course, Lyndon Johnson picked up where he left off. Richard Nixon was one of the most aggressive healthcare presidents we've ever had. His proposals for universal coverage would look very liberal at the current time. And he was out front and outspoken on the need to expand coverage. And when he spoke about it, he almost always referred to his childhood experience with tuberculosis. He lost several brothers to tuberculosis. He himself likely had the disease, as it was discovered by chest X-ray. And he had a special sensitivity to healthcare that is not widely understood. Barack Obama often cites his mother's experience with ovarian cancer when he talks about why he became so committed to healthcare. Now, in President Biden, we have a person who has himself experienced serious illness. He had a cerebral aneurysm that had to be surgically corrected. And of course, there's the widely known tragic history of his family, his wife and daughter, his sons who were injured and were hospitalized when he was first elected to the Senate. And of course, the history of his son, Beau. I think that bodes well for those who are interested in seeing him commit his personal capital to healthcare. It's one of those factors that transcends politics. But I do think we have to be aware that his focus, despite all the other issues that face the American public, his focus for now and for the first 6 months to a year of his presidency will be relentlessly on the pandemic, which is probably where it deserves to be. So I'm going to stop there with my formal comments, and I will take questions if that's possible, or just fade into the background.
Dr. Blumenthal, that was fantastic. Thank you for that overview and that summary of the landscape, both past, present, and future. So thank you very much for doing that. We do have a couple of questions in the chat, but I want to remind everyone that if you have a question for Dr. Blumenthal, we have about another 10 minutes allocated to this keynote address. So if you have any other questions, please let us know. But in the meantime, Dr. Blumenthal, I'll ask a couple of these questions that have been posed at this point. One is from Harsh Agarwal, who's a board member of the North Dallas Chamber of Commerce representing Bank of America. And he said, has there been any initial impact, positive, negative, or nothing, of the previous administration's price and quality transparency executive order?
Well, that order was just affirmed by the courts, the price transparency order. It was under challenge from the American Hospital Association. I think it was affirmed at the federal appeals level. I don't know whether the American Hospital Association is going to appeal that to the Supreme Court. So I think it's premature to expect to see much impact from that rule, which was just finalized and has been under court challenge.
Considering all of the, and I'll just supplement that question from Harsh, and that is considering all of the controversy around transparency and on price and quality, how do you personally feel about that particular executive order?
So I would also add one thing to that, and that is that the Federal Trade Commission has entered this area and is now requiring, basically subpoenaing, from the 6 major insurers all their claims data. So it may be that this price data is going to get out through that avenue independently of the rule that the Trump administration created.
That's great.
My view of that is that it's a step that is inevitable. I'm not confident that it will change the purchasing behavior of healthcare of consumers in the short term. I do think in the longer term that the data that's released is going to be taken by third-party software developers and turned into products for shoppable types of care that will, in fact, guide consumers' choice of healthcare locations.
Thank you, Dr. Blumenthal. That's really helpful. Appreciate it. The next question is from Stephen Angelette, also a board member of the North Dallas Chamber of Commerce and a healthcare attorney at the law firm Polzanelli. And Stephen asks, do you expect the Biden administration to maintain the more flexible regulatory structure for the provision of telemedicine to Medicare patients that was implemented during the pandemic?
I do expect that. I think it would be very consistent with the reform-minded attitude of the Biden administration and the people that are taking over. And from what I know of Secretary-designate Becerra and some of the appointments he's making, I suspect that would be very much consistent with where they're going. And in fact, it's virtually inevitable. I mean, this is something that has proven to be a very constructive addition to the range of services that we provide.
Great, thank you. From Jenny King, our good friend at UT Southwestern. Jenny asks, well, first of all, she remarks that these are fascinating presentation, but can you expand on the Nixon's Universal Plan and how it was received and how we are now compare that to the Affordable Care Act?
The Nixon plan was much more ambitious than the Affordable Care Act. It would be seen in current political terms as not just far left, but extreme left. And it included a requirement for all employers to insure their employees. It would have made Medicaid available to every American. And it would have left Medicare in place. So basically, it was universal insurance with a requirement for employers to cover their employees and Medicare and Medicaid covering everybody else. That was a response at the time, actually, to Senator Edward Kennedy's efforts to challenge or perceived plans to challenge Richard Nixon for the presidency. And Nixon felt he needed something to combat Ted Kennedy's universal health care programs, and he needed it to run on. And that was his plan. His plan was to run on that plan. And then Watergate happened. And his ability to pursue that plan was cut short by the Watergate scandal. And there's a wonderful story about that plan, about how that happened. I wrote a book on healthcare and the presidencies called Heart of Power. And the story is told in detail in that book.
Thank you for that. That's really helpful. So last question, and this one I'm just going to create myself. obviously you were heavily engaged in the creation of the Affordable Care Act, and wanted to get your perspectives. What do you see are the great things that have come out of the Affordable Care Act, and what are some of the things that didn't come out of the Affordable Care Act that you wish had?
Well, I speak now as someone who obviously, I worked on President Obama's campaign. I worked for him. There was a long period from the Clinton failure until Obama ran where Democrats were afraid to take on universal coverage or expansion of coverage. And Obama brought coverage back into the national dialogue. But he did so with careful attention to the failures of the Clinton experience. And one of the failures of the Clinton experience was that he had threatened Americans who liked their insurance with losing that insurance. We are still debating that question of whether we should have on the Democratic left, whether we should do something like Medicare for All, which would obliterate private insurance. And I think the lesson of the Clinton experience that Obama learned was that we should leave people who like their insurance to have it. I think that the result, when you do that, you limit substantially the level of the reforms you can make. And so I think that Obama made the decision to reinforce the private insurance system, but he was limited in doing so by the amount of money he felt he could spend. So his subsidies are not as generous as would be required to make insurance affordable, private insurance affordable for low and middle income Americans. And the result was that when the law was fully implemented, we still had about 9% of Americans who lacked insurance. So I think that was one of the big shortcomings of the plan from the standpoint of progressive Democrats. But we got to the lowest number of uninsured that we've ever had in our history. And 20+ million Americans who didn't have insurance had it, including millions of low-income Americans. And one of the side effects of that was that disparities in access to insurance between people of different race and ethnicity were brought to historic lows. Not to where they should be, but they were brought to historic lows. So I think that was one of the major accomplishments. It fell short in many respects. It leaves a very complex insurance system with many, many different benefits, a lot of complex billing requirements, a lot of administrative expense. But if you believe that we are an incrementalist country, as I do, it was probably what was achievable at the time that he set about to introduce it.
Fantastic. Thank you so much, Dr. Blumenthal. What an honor it's been to have you here joining us today from your global headquarters in Cambridge, Massachusetts. We really appreciate you being here and being part of this. I do respect the fact that you had a relatively short commute this morning, but that's really great for you and for us since we were able to access you to give this wonderful presentation this morning. So I wanted to just quickly close with a comment here about David Blumenthal, our good friend and past board chair of the North Dallas Chamber of Commerce, and also a healthcare leader in Dallas, Andy Stern, actually went to camp with Dr. Blumenthal and his brother, and he sent me some photos from 1963. And under one of the photos, it said, "David Blumenthal, all-American boy, good at everything." And I thought to myself, wow, is there a better description for Dr. Blumenthal? We really appreciate you being here today. You truly were all-American and good at everything in your comments. So thank you very, very much for that.
Well, welcome back, everyone. My name is Stephen Angelette. I'm a partner specializing in healthcare at the law firm Polson PC here in Dallas, and a member of the board at the North Dallas Chamber of Commerce. It's my honor to introduce you to our panel moderator for the modernization of healthcare discussion. Shara McClure, a native Texan and proud Texas A&M grad, who's the Divisional Senior Vice President of Texas Healthcare Delivery at Blue Cross Blue Shield of Texas. Shara leads the healthcare delivery options for Blue Cross, which offers a broad provider network in the state covering all 254 counties. She carries a great commitment to both improving and protecting the physical and financial health of Texans, and has been responsible for some of the coolest, most cutting-edge models for access to healthcare, particularly for rural areas, through her roles at Blue Cross. And so she's extremely well suited to moderate this discussion of modernization. So please welcome Shara McClure. Welcome, Shara.
All right, thank you. Thanks for that introduction, Stephen. And as you mentioned, I'm Shara McClure, Division Vice President for Healthcare Delivery at Blue Cross and Blue Shield of Texas. It is my pleasure to moderate today's discussion on the modernization of healthcare. As a North Dallas Chamber board member, I always look forward to this annual healthcare conference and just so genuinely appreciate the exceptional experience that Ken and his staff have created for all of us here today. I hope you enjoyed Dr. Blumenthal's presentation earlier this morning, as he looks at what we can expect with the Biden administration as far as changes in healthcare. Our first panel discussion dovetails nicely with some of his points as we discuss where our industry is headed from multiple vantage points. When I think about where we were this time last year, we've seen so much change in how we approach healthcare from all aspects, from virtual visits to vaccine distribution to structural design. There seems to be no area left untouched. I'm proud of the work we've done at Blue Cross and Blue Shield of Texas to serve our over 6 million members across all 254 counties, especially through COVID-19, as we've dealt with testing and treatment coverage and now vaccine coverage at no cost to our members. We've also strengthened our commitment to value-based care. We're offering more affordable plans on the healthcare exchange, like one we introduced in 2020 called My Blue Health in Dallas and in Houston. And these are based on a fee-for-value model. This, along with our provider partners like Sanitas Medical Centers, are paving the way for a healthcare experience that's truly based on value and quality. If the COVID-19 pandemic has taught us anything, it's the need for these types of value-based care programs, and we need them to move from theory into reality. Another silver lining to the many challenges we've encountered over the last year is the opportunity to forge even stronger bonds with the communities we serve. Blue Cross Blue Shield of Texas has donated to the Texas Restaurant Association and the Communities of Foundation of Texas. We recently announced a $1.8 million investment into addressing social determinants of health, which impact our most vulnerable Texans by funding areas critical to improve health outcomes. These are like housing and transportation, nutrition, education and jobs, mental health, as well as safe environments. The modernization of our industry starts with our communities. And as the largest health insurer in Texas, we know our members' needs go beyond the doctor's office. Of course, healthcare thrives on collaboration. And to help us navigate this topic further, I'd like to welcome my fellow panelists to the stage, and I'll introduce them and have them briefly talk about what they're doing in this healthcare space. We're going to start with our design expert, Hank Adams, who's Global Director at HDR. Hank's a graduate of Oklahoma State University. He's board certified by the American College of Healthcare Architects. He provides leadership and inspiration for HDR's award-winning healthcare design practice, and he's a recognized expert in planning and design with over 28 years of experience in academic medical centers, community hospitals, ambulatory facilities, and global health. Welcome, Hank. Can you tell us a little bit about yourself and HDR's role in the future of healthcare design?
Yes, thank you, Shara. Appreciate the introduction, and I'm really honored to be here today for this in-depth discussion about the modernization of healthcare. As Shara mentioned, I'm the Global Director of Health for HDR. I'm a lifelong healthcare architect. My career long, at least. I've been practicing healthcare architecture for about 34 years, and 20 of those I've been with HDR. I'm actually based here in our Dallas office. This is my home and my community. Actually presenting from our office here in Dallas. And we are a global architecture and engineering firm that spans across the globe. We are headquartered out of Omaha, Nebraska, but we have a presence here in North America, in Europe, in the Middle East, in Asia and Australia. In my role, I'm involved with helping lead our healthcare practice, and we have a very robust practice that involves more than just architects and engineers and designers, but a lot of consultants and strategists and data analysts. That really kind of brings a lot of depth to our practice, and we're excited about that. I just want to mention a few things about our Dallas office. For those of you who live here, some of our notable work we've completed here in Dallas includes extensive master planning and expansions at the Baylor Scott and White Baylor University Medical Center campus and at the Grapevine campus. We've been a great partnership with them for 20 years now with Baylor Scott and White. We also designed recently the UT Southwest, the Building 3 on the West Campus, a new ambulatory center. Incredibly proud of the simulation center that we have there in the training that's training the medical professionals throughout the region. And then our largest and most notable project is the new Parkland Hospital here in Dallas. And I had the incredible opportunity to be the design manager for that project that really changed the medical district. Just to set the lens for our discussion going forward, I did want to say, first of all, that I'm deeply humbled by the economic and the human toll that the pandemic has taken on our industry. And, you know, we're in design industry. We're not necessarily frontline workers with patients, but I just want to say thank you. I know many of you that are on the call today have a huge hand in that. And I want to say thank you from the bottom of my heart that it's been a really tough go this year. And I do think, from my perspective, I'm an optimist. I do believe that this has been a disruptor in our industry. We have a chance to really change and do things better as we go forward. And there's a quote from Winston Churchill that I've held my entire career that talks about we shape our buildings, and then forever they shape us. And so, as an architect, we have a humble and a role in the built environment. And I just today, that's the lens that I'll be able to contribute to this panel. So, thank you, Shara.
Thank you, Hank. So next we have John Phillips. John is the president of Methodist Dallas Medical Center. John has undergraduate degrees from Abilene Christian University and the University of Texas Southwestern Medical Center at Dallas. He has postgraduate degrees from Hardin-Simmons University and Trinity University. And as president, John has been instrumental in leading and growing Methodist Dallas Medical Center to magnet designation for excellence in nursing. Welcome, John. Can you tell us a little bit about your role at Methodist Dallas, which has been at the epicenter of much of COVID-19 activity?
Thank you, Shara, and thank you for that introduction. It sounds like I can't figure out where I want to go to school or what degree I want to get now that I reflect on that. What an honor to be here. And Hank, you and Shara have set this up perfectly. It's hard to follow you two. You know, Methodist Health System has started right here where Methodist Dallas is in North Oak Cliff in South Dallas 94 years ago. And what a humbling honor it is to be part of Methodist. You know, we've expanded over the 94 years all over the Metroplex. Methodist Dallas still being the flagship hospital, but, you know, we have hospitals as far north as McKinney, all the way down south. We just in November of 2020 opened our newest hospital in Midlothian, Texas, down south in Ellis County. And then if we sweep around, a hospital in Southlake, and then all our other hospitals are kind of in between, serving North Texas and the Metroplex. So it's just an honor to be a provider on today's panel. You know, I'll say I'm not worthy to be the provider person, I guess, representing our providers on this panel. I know we have a lot of other health systems that are part of today's conference, and those leaders would probably join me in saying that there's nurses, respiratory therapists, housekeepers, doctors, physicians, food service staff, physical therapists, all that should be sitting in this seat telling you their experience in moving through the COVID-19 pandemic. And those truly are heroes that I get to serve with every day. So I will hope to build upon that a little bit more as we get talk today. But again, just an honor to be here. And just want everyone to know that, maybe isn't a provider, but has friends who are providers. No place is perfect and no part of the country is perfect, I imagine. But Dallas-Fort Worth, I believe that we are really, really good. And we have amazing healthcare systems in North Texas. Some of the big names, and then there are small hospitals and they're more rural parts around the Metroplex that are doing a magnificent job of working together and making sure that the highest quality of care is being delivered to patients during a pandemic. And then there will be better days ahead. And so when we get to those better days, our healthcare providers across the Metroplex will be providing even better healthcare at that point. So thank you again for having me today and for allowing me to share just a little bit.
Thank you so much, John. Finally, we have Dr. Asim Saeed. He currently serves as lead for the Digital Health Office at Baylor Scott & White Health. He got his undergraduate degree from Rice University. He has an MPA from Harvard Kennedy School. He got his medical degree from Duke University School of Medicine. He co-founded Livewire Incorporated, which later was purchased by H&R Block. As lead for the Digital Health Office at Baylor Scott & White Health, Dr. Saeed helps evaluate, select, and implement technologies that support major system initiatives like digital transformation, consumer digital, and virtual health. Dr. Saeed's background intersects clinical experience, a consulting skill set, and technology entrepreneurship. Thank you for being here, Dr. Saeed. You have extensive experience leading up to your time at Baylor. Tell us a little bit about that journey.
Sure. First of all, it's a pleasure being here. Thank you guys for inviting me, and really excited to speak to whatever that context can provide, that perspective. As John called out, I don't want to misrepresent that the clinical staff during, especially the COVID crisis, have really been the kind of forefront of heroes of what we do. But fortunately, I think my journey and my background are lending to helping support that with a lot of digital health interventions these days. But you asked, Shara, about a little bit of my background. And so I'm a Texas native, grew up in the Houston area and trekked very slowly up I-45 to college, and then made my way here to North Texas eventually. The experience has been incredibly serendipitous in the sense that when you look back, I think doing clinical training, consulting in the world of McKinsey, and then now in tech entrepreneurship intersect really well with the position I hold right now. I wish I could say in hindsight that was a plan that I had laid out. It was a lot of left and right turns that confused and confounded my parents along the way quite a bit. But I can tell you that it's incredibly serendipitous, especially on the other side of the COVID crisis and the quarantine this last year, because those skill sets intersect really well with, I think, hopefully the reality and the perspective of clinical frontline workers, what they need and what how healthcare works today. Consulting, understanding the business side of healthcare, what financial models and business models work in our U.S. healthcare system. And then technology entrepreneurship, enough of kind of healthy disrespect for the status quo, the willingness to leverage technologies in new ways and to push boundaries for how we implement care and service models that may challenge the norm and challenge our providers to learn and utilize new technologies. And so I sincerely hope that background has been a service to Baylor Scott & White the last 3.5 years that I've been here. And again, the uptake, which I'm sure we'll talk about, of digital tools to rethink how we deliver healthcare in this country has been expedited in ways that we could have never dreamed a year ago.
Agree. So thanks to all of you for taking time to be here today. So let's go ahead and dive in on our questions. So my first question is for you, John. John, Methodist was one of the first 4 sites in Texas to receive the COVID-19 vaccine. What was that like, and how have you equipped the organization to handle the unique administrative and delivery challenges that we're all seeing throughout the country moving forward?
Well, I think as I answer that question, let me set it up a little bit with, I think, all organizations, regardless of our industry, you get results, or the results you get are reflective of the preparation that your organization has put in, and just really the culture of your organization. And so I think as we across all industries in North Texas see good things happening in various parts of our industries, it's because I believe a lot of work has been done in the decades and the years leading up to our current time. So all of my answers will be, giving credit to people that have come before me at Methodist that have really done a great job of establishing a strong culture of innovation and a strong culture of teamwork and really just resilience. Dr. Blumenthal spoke about a few things that, and by the way, so I can officially check off my bucket list, share the same stage with Dr. Blumenthal. We can all do that, right? If there was a photo of me at camp, underneath it would say fairly average and usually annoying. So I'm not quite Dr. Blumenthal, but what an honor to get to share the stage with him. And as we talk about the vaccinations, on December the 14th of this year, the first vaccinations were given in North Texas, and that was right here at Methodist Dallas. And we were the first in North Texas to receive the vaccine, and then immediately after us in coming days, most other healthcare providers started receiving the vaccine and immediately giving vaccines to the appropriate people who were qualified or slated to met qualifications to receive the vaccine. And I'll think back, and when you think, wow, have we gotten here? So last January, so about a year ago, we're all of us in this conference today are starting to experience anniversaries, pandemic anniversaries, right? We can all remember about a year ago, we heard about this virus in China, right? And then about a year ago at my hospital, I heard my infection prevention medical director say, we need to be ready. So here we are in January, we need to be ready. And all of us kind of wondering, well, is this really going to happen in our country? And then I remember where I was on March the 10th of 2020. I was actually at a Leadership Dallas event with Dr. Phil Wong, who's such a wonderful leader in our community through this pandemic, our top physician at the Dallas County Health Department. I was with him when Methodist Dallas, my hospital, had our first confirmed COVID-19 case, and we were ready. And so I share that as a precursor to December the 14th, when we administered our first vaccines. There were people in all of our health systems. I know people at Methodist and at Methodist Dallas who had been preparing for this, and so we weren't caught off guard. And I don't think any of us could say our responses were perfect, but they were really good because we were prepared in North Texas as healthcare providers to work together and to share information. We don't compete on COVID-19 in North Texas, the health systems, we collaborate. Steve Love is going to be a panel moderator, I believe, later this morning. Everyone knows Steve is president of DFW Hospital Council. It's a luxury, in my opinion, to have a hospital council. Most metro areas do not have a hospital council. And year over year, Steve helps demonstrate the value of the hospital council in Dallas-Fort Worth. This year, Steve has served as the voice, the convening voice of health systems, which has been extremely helpful to make sure the right and accurate information is getting out to the community to help guide our response and people's information that people receive. I was sharing earlier that back in the summer, in this culture of always and the culture of preparation we have at Methodist that I see across our industry in North Texas, our vice president of pharmacy at Methodist came to me and said back in June or July, hey, John, we need to buy a freezer. And he gave it for the vaccine. We think Pfizer is going to have a vaccine that will need to be stored at this remarkably low temperature. And he gave me the cost of the freezer. And I said, are you sure we need to do this? So I guess that was a lesson in, listen to the smart people that you have that are around you, because we did that and we were prepared. And it was things like that got Methodist prepared to the top of the list so we could receive the vaccine and be ready to provide it. We prior to December the 14th, leading right up to the weekend before the December the 14th, we really weren't sure if we were going to be the first to have the vaccine, but we went ahead and had the vision. Smart people here had the vision to get ready, set up our vaccination site. I would say the corporate leadership, all the way up to the president of our entire health system, was physically boots on the ground in our vaccination auditorium. Our vaccination clinic, we call it, right here at Methodist Dallas. And so senior leadership being involved in helping lead by example was very encouraging to our staff. We've had really no problem having volunteers sign up to staff our vaccination clinic. And to date, as of last night at midnight, we've vaccinated over 13,000 individuals have been vaccinated through our HIT auditorium. Growing up in rural Colorado and rural West Texas, that's a couple sizable West Texas towns that we vaccinated. And so we're very encouraged by that, very encouraged by the results we're seeing, research study results we're seeing from the Pfizer and Moderna vaccine, and excited to see what happens next. Several providers in North Texas have been designated as hubs for vaccination administration. So we really look forward to seeing how quickly we can continue to vaccinate people in North Texas.
Well, good luck and thank you. And that's great news that you've had success so far. So next, let's talk a little bit about telehealth. I know that at Blue Cross and Blue Shield of Texas, we saw our telehealth volume skyrocket, and it's leveled off, but it's still a lot at greater levels than it was before the pandemic. So let's go to Dr. Saeed. Telehealth, the utilization, it's gotten a lot of attention during the pandemic. So 2 questions. How does virtual health impact the standard or quality of care? But then secondly, what does this do to the future of the physician-patient relationship?
Great questions. So I got to say, there's been this open question about quality of virtual that, especially in the state of Texas, has led, I think, to a lot of resistance to video visits. Necessity is the creator of all invention. I think that all went out the window the day quarantine hit, right? Immediately, I think we were asked for technologies that forever had been kind of put on the back burner or repressed, and frankly, available to the public. I mean, how long has the world had FaceTime for a decade before we finally decided it was safe to adopt in healthcare? So I think there's a lot of Monday morning quarterbacking we could do there to kind of self-reprimand ourselves as an industry. But the reality was, I think less so than the safety issue, the bigger challenge, I think, has always been reimbursement. I think ultimately the industry has a long way to decide what virtual will be in the future. And by the way, I don't think this is a single-sided issue. I think there's a challenge to say, from a provider perspective, reimbursements have always been lower for virtual care, whether it's telephonic and or video related. The step down of reimbursements present a meaningful disincentive for making those things accessible, especially in non kind of value-based care arrangements. If you look at other parts of the country where you have big, large health provider systems with value-based care populations, there's been very little resistance to virtual telephonic care, in their entire history. That being said, I think reimbursement on the other side of the aisle, trying to be very empathetic to our other industry colleagues in the payer world, including yourself, is completely fair in the sense that if you have alternatives like the Teledocs of the world at low costs compared to primary care, which might be twice as expensive, you have to ask yourself, why am I going to reimburse exclusively at that rate when that option is on the model? That model is on the market that doesn't account for all the infrastructure costs that we know are leading to those higher costs, the clinic, the front office staff, and other things. And so I think what we're at a challenge to do is really ask ourselves, how can we meaningfully take the increase in virtual visits that COVID was, if anything, the silver lining of COVID, and say, how do we make this the norm? We know it's more convenient for patients. We know that providers, once they get used to the technology, can be more efficient this way in terms of being able to provide good, efficacious care and focus on the relationship still. And we'll talk about the relationship question you asked in just a second. And because you've digitized it, and this is a big if, but if you truly digitize that process, you're also increasing efficiencies of upfront registration, rooming, data collection that you can be doing ahead of time while the patient's filling those forms out digitally instead of having, a dozen different forms at a dozen different clinics. And so all of those opportunities are there. But again, I think reimbursement's a big open question and what happens in the next coming months. And the second variable, I think, would be consumer demand. Once consumers have had this experience, are they really willing to go back? And then lastly, can provider models adopt? If, let's say, the answer for reimbursement is somewhere in between, the Teladoc style reimbursement versus the full physical reimbursement, then can you adapt to provide that convenience? Can you make it a differentiator either on volume, or can you reduce your cost structure to account for that by having physicians practice, one day out of the week at their home or other things? I think that video is a big part of this, but it's only the beginning. The other big element of virtual that I think people are very familiar with video, but often forget is asynchronous, remote monitoring. Those types of digital care journeys, or what we call digital care journeys, are also really an amazing, interesting opportunity in virtual that we're seeing a lot more traction with. We, as Baylor Scott & White, for example, had looked for opportunities to pilot what we call digital care journeys, pre-operative and post-discharge. And there was a lot of inertia in the system. And post-COVID, we have literally launched completely in all of our major facilities a asynchronous digital care journey for all preoperative care and all discharge leaving hospitals. And that was unheard of, undreamt of, unthinkable before COVID. So our hope is that in the relationship question you asked on the second side, that finally we're past this barrier of, is it safe, is it acceptable? We're now in the space where consumerism, the customer experience, the convenience and access that it enables are not questions anymore. Question is, how fast can we adapt before Amazon really starts to make that offering? If we're too slow, that's the biggest threat, that somebody else is going to professionalize it and come in and offer it to payers and to employers faster than we are. So it's really in our own best interest to figure out how to get there sooner.
Thank you. And as far as the reimbursement question, I do think that we're more aligned on reimbursement than we have been in the past. And I know that one thing that we've seen on when it comes to virtual visits, we see many more. The majority of virtual visits are actually with patients and their regular providers. Not, we've seen an uptick in the vendor volume, but it's been more around individuals who have those relationships with their provider. Yep. So thank you. So now let's go to you, Hank. As we think about designing facilities for the future of healthcare, what are some examples? I mean, this we'll get past this. What are some post-pandemic considerations that you'd like to talk about?
Yes, thank you, Cheryl. I mean, I think the one thing, the pandemic really has been an incredible disruptor in the facility and design and construction part of the industry. I can't think of any time in my career where we've had to pivot and change so rapidly. And as John was saying, the early work that was done when there was just a hint of the pandemic starting and coming to the shores of the U.S., we were in the same kind of boat where clients were calling us up and saying we're dealing with triage problems, we're dealing with potential surge capacity issues. And the thing that I learned, I think, from those early days is that the health systems that had relationships with consultants, with vendors, they were able to very quickly, rapidly address these crucial problems that they were dealing with in such a fast way. We partnered with builders, and we were able to implement projects, temporary structures for triage and access to hospitals. We were able to rethink flexibility. We were part of surge capacity. We designed some arena projects. And we were able to mobilize really fast and pivot our focus. So we got through that, but we learned that the problems were complex. They weren't just about facilities. It was about PPE. It was about having staff to run those facilities. It's a broader network of needs. And so I think looking forward, we are starting to take a deep breath now. We're still deep in the pandemic, obviously in the second wave. But we are starting to look at that post-pandemic facility considerations. And we have to think about resiliency and disaster preparedness very differently. This pandemic was different than the Ebola, outbreak in 2015. The way the transmission of the disease happened, how it impacted our communities. So I think it's going to force our industry to look very, very carefully at what is real flexibility in our networks, both acute care and ambulatory, and really rethink about surge capacity and how we serve communities and how we serve rural communities and also urban communities like Dallas. So I think, and as Asim said, the silver lining of all this was that technology was pushed forward in something that probably would have taken another decade, with sort of the glacial pace that sometimes policy takes. So I'm optimistic that I think that as this goes forward, we're going to learn a lot about how we approach our facilities and start to look at them in a more clear manner. And I think we're starting to collect data right now. We're working closely with New Parkland Hospital because the new facility has been open 5 years, and they're one of the epicenters for treating COVID patients here in Dallas. We have a research study. We've done extensive interviews there, understanding what worked and what didn't work, and how we can apply that to the future. So I'm excited from the lessons learned we have right here in Dallas as well.
Thank you, Hank. So let's shift. I think we've heard about, John, you've given a lot of credit to the frontline workers, the doctors and nurses and staff that are treating the patients who are really dealing with some surges right now. And we know that this pandemic has taken a great toll on healthcare workers. How do you keep your workforce motivated?
Great questions. I think what all of us have done in our businesses and industries pre this pandemic, and what we learned to build the best staff, the best teams, the best workforce in all of our industries. As I reflect, those same principles still held true during the pandemic. However, the cadence, the frequency, the intentionality of all of those best practices just seem to be magnified. Where, as an example, I think number one on my list of keeping people motivated, keeping our team at Methodist and at Methodist Dallas motivated would be information. They want information. The more as a leader you can communicate to your team, that void, that silence is filled with accurate information, and that helps. People want to know what's going on. Pre-pandemic, I probably would have felt my weekly update to my staff would have been enough, and as I reflect, the cadence of that has picked up to sometimes daily getting information. Well, actually, always daily since April, getting information out to staff on a daily basis and our medical staff so they know the status. And that's been good. And that's probably something that we're learning from that will continue to some degree going forward, even when things do get better. So I'd say number one, just communication. Number two, transparency, making sure that staff, medical staff, community members that we serve in our organizations, that they feel like you're being open with them and you're sharing information that is accurate and helpful and applicable. And then, I've been a lot of conversation around, this is a marathon and not a sprint. And I think Dr. Blumenthal kind of touched on this earlier, that we've been in this a long time. I think a lot of people, all of us, are fatigued to some degree. And so it is a marathon, not a sprint, but we still have to act fast. We have to move quickly. And so I've have some friends that are marathoners, and what I understand is, yes, marathons, you have to pace yourself, but there's people that run really fast marathons and there's people that don't. And so we are learning to be really fast marathoners. Pace yourself, but at a faster pace than normal has been a learning that I think our staff would say has worked for them. And then be visible. That would probably be my top four. My fourth one would be visible. People want to interact with one another. It's hard because, in a lot of our hospitals, we do have cohorting areas for infection prevention, best practices. There are staff that truly do feel isolated because they are, right? They're isolated with patients to keep patients safe. The limited visitors that we've had in hospitals, we want to keep them safe. And so things are just not like they usually have been. So people do feel isolated. There's many of you that have not been to your office in a year or close to it probably. And there's a feeling of isolation there. So I think in the hospital and healthcare setting, the more leadership can be with staff and shoulder to shoulder safely participating with staff has been motivating to our staff. And then, I just can't say enough about the business community that is either maybe tangential linked to healthcare or maybe not linked at all to healthcare as providers. You all have been tremendous. The outpouring of compassion and caring and love towards the healthcare providers in North Texas has been wonderful. Not overwhelming in a bad way, but overwhelming in a, wow, I can't believe we're this awesome way. And so thank you. If you're one of those individuals or one of those businesses, one of those leaders that has made a plan around helping health systems and hospitals and doctors' offices and urgent care centers during this time, just know that has not gone unnoticed, and that has been very motivating to staff.
Thank you. Thank you, John. So, unfortunately, a lot of healthcare workers, yes, they're doing digital virtual visits, but many don't have the luxury of working from home, but many of us do. So Hank, let's go to you. Have you seen opportunities for non-traditional partnerships in the healthcare design space? So like overlap in your work, helping inform corporate office design, as a lot of these offices are working from home and might continue to do that even post-pandemic.
We have, Shara, we've been involved in a number of opportunities since the pandemic began that both with working with our design teams that focus on commercial properties and in real estate and workplace, but also in transit and transportation. We did a study for a new terminal that's being designed right now in Pittsburgh, and working with our HDR team that's designing that and looking at how disease transmission happens and how to pivot and safely move passengers through the terminals and through the various pathways, and using healthcare principles and biocontainment principles to provide a safer environment. And so, there's lots of opportunities like that. I think the one sort of thing I want to focus on today is that I think one of the big opportunities that we're seeing in healthcare design is really coming also from what Dr. Blumenthal mentioned earlier was about how the social determinants of health define healthy communities. And I think that we recognize that there are major factors in the communities, and clinical care is part of that. But it's not actually the largest component of the social determinants of health. It's contributing to support communities, but really healthy behaviors and the social and economic factors and the physical environment of a community really does improve wellness. And so one of the things we've done with our health sector is working a lot with urban planners, community planners, and developers and healthcare clients, and looking at new models of healthcare delivery and care and new facilities that are integral to our communities. And we have two examples that are both into the spectrum right now. We're designing. I'm super excited about. One's in Chicago, with St. Anthony Hospital and what's called Focal Point Community Campus. And that's where we did a research study in Southwest Chicago to determine what that community really needed in terms of helping to provide a higher level of health and wellness within the community. And then that led to a mixed-use urban hospital that has complementary education, community resources, social networks together. And then on the flip side of that, we're also doing that with a rural community and actually in Haxton, Colorado, which is a small town in western Colorado out on the plains. And we're doing that in a project to sort of reinvigorate their Main Street by creating a new critical access hospital and long-term care facility to reinvigorate redevelopment back into a rural community. And the needs are very much the same. So I'm excited about the opportunities for us to really help and complement where it'll make a big difference and really change the outcomes for our communities.
Thank you, Hank. So I'm looking at some of the questions in the chat as well as the Q&A, and I'm going to try to combine a little bit and go to you, Dr. Saeed. So there was one question that was, please tell us more about the digital health journey, and I'm going to combine that with another question. In the at-home space, and you touched a little bit on remote monitoring, do you see systems and payers moving more deliberately into the creation of a deeper partnership into the post-acute and telemedicine space? So I guess a little more about the digital health journey, what other areas might be ripe for transportation, and then do you see more collaborative partnerships as we digitally deal with post-acute care? It's a lot. I think you're on mute. There we go.
Into the mute nickel jar, as we say here. Yes, let's talk about digital care journeys, and then we'll try to touch on post-acute and other opportunities like remote monitoring. So the digital care journey was a concept, again, we had well before COVID, with the idea that says there's a lot that you could be doing to help facilitate patients' understanding and information of where they are in their healthcare experience and journey and navigation. That does not rely on individual people. Not everything has to be a phone call. Not everything has to be a conversation. And so what we envisioned originally was something that could, in our mobile experience, the MyBSW Health app, send patients information, whether that's diagrams, pictures, instructions, or information of other sorts. Solicit information, ask them questions. How are you doing? How is your recovery going? Do you have a fever, etc.? Anything from patient-reported outcomes to just general questions about their eligibility for certain services. And then really involve the care team as needed. And so escalations to care team members if you have a fever, if you have pain scores of 7 out of 10 or other things, but then automated experiences if that pain is well controlled or if you're doing great about what's the next step in your journey. And that really was something that we were pushing and trying to create and pilot well ahead of COVID. But like most things in the virtual and digital space, COVID was a massive accelerant. So specifically during the initial surge in DFW, one of the things that we focused on was everything that we could do to try to suppress the surge. And one of the big options in that arena was to try to keep patients who had low acuity, low risk, or very minor symptoms out of the healthcare facilities. That sounds interesting for a healthcare system to say, like, stay away, don't come to our facilities. But we all know that's where we were in July and May. And so we created and launched in, I think, 3 weeks at that time, which is faster than we'd done anything in the space. We were at like a regular interval of months and years before that. But in that point in time, we launched what we called the home monitoring, the COVID home monitoring digital care journey. So we had in our mobile experience, you could sign up. Anyone off the street could download the app and register as a new customer or patient. They could take unlimited amounts of COVID screeners. And to date, I think we've done 250,000 plus of those for the DFW market alone. And then if appropriate, you were directed to a COVID screening test. And again, only if appropriate. If testing scarcity was a factor, then this was a centralized place that would say, you only get a test if you're high risk or not. And obviously, we know that became less of a problem later. And then lastly, if you were, again, low risk and confirmed to have COVID, instead of having treatment or someone calling and checking on you, because we know symptoms could get worse, this automated journey sent you twice daily symptom checks that made sure you were doing all right. And if needed, if your breathing or fever or anything else progressed, then escalated to a care team member who proactively called you. And that lasted 2 weeks of automation. You could opt out if you were tired of it and if it was going well for you. And we conducted and had at least, I think, 15,000 people this summer start and complete that journey. And that was an amazing example. I think that opened everyone's eyes, because all of what I just described would have been hundreds, if not thousands, of man hours, women hours to do that work. And this was something that once we created, it was automated. It was an entirely better experience for consumers to understand that they're being watched and checked after, and to have that experience digitally and convenience through their mobile phone. And for us, it saved us time and effort, money, and really during the surge, deferred patients. And so I think that's kind of the beauty of what we're trying to create, and what we really think the opportunity for digital is places that give consumers better experience while simultaneously reducing the impact and the effort of clinical staff. And ideally, standardization, higher quality, all of those good things. So that's the digital care journey. I think if you take what I just gave as an example, and then if you can figure out how to add remote monitoring, add things that have blood pressure cuffs, add things that have weight scales for heart failure and other things into the mix, and rely on that kind of automation as well, that's a huge opportunity to collaborate in the post-acute care space. I know Baylor Scott & White will we'll be putting a huge emphasis on home and trying to keep people home and trying to discharge from the emergency department to home or discharge from hospital earlier, and using these kind of asynchronous opportunities to check in on people, as well as remote monitoring technologies and others, will just increase our options for doing that comfortably and safely. The challenge, and this is a theme, and I hate to be the cynic here, is like we have to figure out the reimbursement model for these. It's always the hardest part. So Shara, to your question, I look forward to more partnership with payers, because I think it's going to be required, because that's the biggest challenge in a lot of healthcare is we always have to figure out, okay, here's the thing, it's clearly a good idea, we want to do it, patients want it, but is it the way that our healthcare system works, and are we rewarded for it? If we can figure that out, then this is all golden. We have the technology. Again, FaceTime has been around for a decade. It's not rocket science to get this stuff together. It's a lot of workflow changes for providers, so I don't want to minimize the impact it has on reteaching clinical staff to leverage these things, and also a non-negligible amount of new data that's being created and questions of liability and when that data is coming in if we don't act on it and other things. So there are complications, but that happens in any industry during change. I think if we can align payment and reimbursement and value models, we want to be at the forefront of this. I'm sure other providers do as well. And so the more we can have collaboration with payers, the better and faster these things will get out in the market.
Well, thank you, Dr. Saeed. Thank you, John. Thank you, Hank. We have a lot to look forward to in 2021 and beyond as we continue to see healthcare evolve. And with that, I will wrap it up and hand it back to Ken Malcolm.
Great. Well, Shara, thank you so much for moderating this very engaging panel. I've received multiple text messages outside of the chat about how engaging and insightful and meaningful this conversation was. So thank you very, very much for moderating today, Shara. John, Hank, and Dr. Saeed, thank you so much for your participation. Blue Cross Blue Shield, Methodist, HDR, and Baylor Scott & White, all sponsors of today's event. So we can't thank you enough for your sponsorship as well. So we really appreciate y'all being here. You all are all Americans in your own right, in spite of what John Phillips said. So we really appreciate it. What a privilege to be in the presence of healthcare leaders like yourselves. So we really appreciate it.
So Nathan and Chris, welcome. Thank you for doing this today.
Good morning. Great to be here.
Morning.
What we have decided to do in the format we've chosen is each of the panelists are going to give some opening comments, opening remarks, and they're very important because we heard a great presentation this morning from Dr. Blumenthal related to the federal government. He even went back and gave us a good history lesson on the presidents. Well, we've got to also realize it's a federal-state partnership when you get into Medicaid, and the uninsured in Texas is the highest in the nation. We lead the nation as having the highest uninsured. Approximately 1 out of 5 people in Texas does not have health insurance. Very, very serious problem. So without any further ado, we'll turn it over first to Senator Nathan Johnson for his opening remarks.
Thank you, Steve. Good to see you again. And Chris, always good to see you. We've done a bunch of these things and we're talking about it. I can't think of a more important topic for the business sector and the government to be considering right now than the healthcare space generally and the problem that Texas has with the uninsured in particular. I want to spend some time this morning talking about where we are politically, what our alternatives are, what are the things that are being done right now and what's their significance and what isn't their significance. And one of the reasons that this has been an intractable problem for Texas is that it's difficult stuff. It's hard to understand. And there has been absent, I think, from the public dialogue and from the political dialogue, facts, information, and understanding of the economics of healthcare. And one of the reasons it's such a, not just an important area for us in order to correct a problem, but such a tremendous opportunity for this state is that by addressing a profound social and human problem, we actually have huge economic benefits. And what could be better to solve a social problem and get rewarded with economic benefits to all of us? So it's hard work. It's hard stuff to understand. But once you take all the details and really study them, it boils down to something pretty simple. We can take care of people and make money. That's a pretty good deal. So I'm honored to be on the panel and to be in such regular communication with business leaders in North Texas and throughout the state, as well as healthcare leaders and patients' rights advocates. And I think we're very close to doing something. I don't want to be trite and say historic. History is a long period of time, but at a minimum, it's significant. And it could be, even to use the other word, transformative. So I'm hoping that we all put our efforts behind it and come out with something this May tremendous for the state of Texas.
Thank you. And Chris, we look forward to your opening comments.
Steve, thank you very much. And let me add to my appreciation to Ken and Jeff and the great team at the North Dallas Chamber for hosting this conference. Many of you that are tuning in, they may not be aware, but our region has a very robust regional chamber coalition. And of the just over 100 chambers in our 13 county area, 9 of them have very heavily engaged government affairs issues and teams. And so what we have done at the commission is we have pulled those 9 together, plus the commission. So 10 of us have taken the top 10 issues of the region, and we've divided and conquered. So for instance, the North Dallas Chamber is heading up this particular issue, healthcare and particularly Medicaid expansion, as one of our top 10 issues of the region. We had just over 40 mayors in our region sign on to those top 10 priorities for the 87th session. So what you're seeing is a unified approach to advocacy on behalf of all 13 counties, which is very, very important. And this issue is one of the top 10 issues. Steve, let me first say thank you very much for your leadership during a very unprecedented time. You've been a valuable resource to us, to our region, and a very credible voice. So thank you very much on behalf of our hospitals. And Senator, as always, your vision for this issue, and particularly your steadfast leadership to get this done in some form this next session is very much appreciated.
Thank you. Thanks for those kind words.
Let me kind of build on what the Senator and Steve were saying earlier, that North Texas leads the country in many, many areas that are positive. And we're very happy for that. We are the envy for site selectors all across the entire country of companies moving here every single week. And that's going to continue because of our low regulatory environment. We have a lot of great assets, particularly our high-skilled, educated workforce. But as Steve said, we also, unfortunately, lead the nation, not only on those assets, but we lead the nation in the highest rate of uninsured residents, about 18.4%. But you compare that to the year's average of about 9.2% and about 7% in the states that have already expanded Medicaid. That's a big delta that simply needs to be addressed. And Steve, as you know, 27% of people coming to our region's hospitals are uninsured. And of course, that creates a significant burden for our hospitals and has resulted in many hospitals have closed. I have relatives in rural North Texas, and their hospital has closed. So they are driving 30 to 45 minutes for emergency care. And that places a great challenge, particularly on our EMS system. So as we all know, that this COVID pandemic has certainly reinforced the importance of having adequate services, supplies, and staff to address the needs of our North Texas hospitals. And let me just close my opening comment by saying that we can no longer afford to ignore the opportunity that Medicaid expansion would bring to our great state of Texas. This is recapturing our federal dollars to reimburse our healthcare providers. Medicaid expansion in Texas would basically return our tax dollars from DC back to the great state. And I'm sure we're going to talk about it, but 38 states have already expanded Medicaid. Think about that. So funds from our federal income taxes that we pay are going to 38 states, including California, Ohio, Pennsylvania, and New York. So these funds pay for health care for those states' residents, not ours. So it's time that we recapture those dollars in a sensible way to expand Medicaid. So I look forward to our discussion today.
Right. Thanks for that. You know, I'm going to start the questioning. And Senator Johnson, you know, you and I deal with this every day. But I think many of the people that are watching this probably don't understand the complexity of the Medicaid program. And Texas got a Medicaid 1115 waiver approved, but we still have not expanded Medicaid. Well, I was actually on a virtual meeting with Executive Commissioner Young from HHSC yesterday. And of course, she's real excited, and kudos to her and to her team. They got that Medicaid 1115 waiver extended, which we're real happy about, but it's got directed payments in it, and how they're going to be allocated and done is still very much up in the air. I would like your thoughts on the extension of the Medicaid waiver and that impact on Medicaid expansion.
Thank you. One of the most confusing things of all is the number 1115, because Texas has been operating under an 1115 waiver for 8 going on 10 years. And as you said, it was just renewed in a form, sort of renewed or recreated for another 10 years. So that's our 1115 waiver. But when we talk about Medicaid expansion, and when we talk about politically the inability to do just a simple Medicaid expansion, we talk about a different 1115 waiver, an expansion waiver, whereby we can do the same Medicaid expansion, draw down those same dollars, but customize it in a way that works with our the structure of our indigent state healthcare system. So already there's a confusion of, hey, wait, you got your 1115 waiver, you don't need your 1115. They're two different waivers. There's a non-expansion waiver and there's an expansion waiver. The non-expansion waiver really was born out of and continued out of Texas's continued refusal to expand Medicaid. It's there to take care of uncompensated care for people who are uninsured in hospitals, for shortfalls in revenue because we have such a high uninsured population. It's also there's two big components. There's DSRIP and there's uncompensated care. And the uncompensated care we just mentioned, DSRIP is a way to get healthcare providers to find better ways to deliver more care to more people for less money. And those programs have been going on for a long time. They've been floating us financially for a long time, but they were never designed really to address the problem of the uninsured. So when CMS, Center for Medicaid and Medicare Services, recently granted Texas a new 10-year 1115 non-expansion waiver, what we've done is really created a backstop. We've effectively continued the status quo, but a little less, because we're going to get the same uncompensated care treatment, but all that DSRIP money, and we're talking about billions of dollars a year for the last several years, that's not for sure. These are programs, new kinds of programs designed to replace DSRIP that have yet to be really fully fleshed out and yet to be approved. So we don't even know how much money we're going to get. What we do know is that some of the things that were going on under DSRIP ain't going to survive because their funding is going to go somewhere else. And so things like certain dental care, certain mental health care, there's one other major category. Suffice to say for the moment that there's many things that we've been relying on for both indigent, uninsured care and other forms of care that aren't going to be there. So while it's a bit of a lifeline, it doesn't address the problem of the uninsured. The new 1115 extension, or whatever we want to call it, the non-expansion waiver, ensures a total of 0 people. A Medicaid expansion, whether it's a straight expansion or pursuant to an 1115 expansion waiver, ensures around 1 million people. The renewal of the old system gives us money at 60-40, 40 Texas dollars, 60 federal dollars. A Medicaid expansion 1115 waiver gives us money at 90-10, $90 from the federal government for every $10. They're not similar. They're not meant to address the same problem. And what's critically important is that people not confuse the two. If you're confused already, boil it down to this. The renewal, the extension, whatever you want to call it, insures no one. It draws money down at 60-40. An 1115 expansion insures 1 million people, draws money down at 90-10. It doesn't mean the other one's no good. In fact, it's a perfect complement to a Medicaid expansion because we have 5 million uninsured people in Texas. We're going to pick up about 1 million of them with an expansion. We've still got another 4 million people that are going to be getting their care at the emergency room. And our system can't sustain that. So it's great that the federal government will continue to help us with the continuing problem with an uninsured population. But it is not, in any respect, a replacement for Medicaid expansion. And it should take no wind out of the sails, out of the progress that we've made, that Chris Wallace has made, Steve, that your voice has been behind, that the North Dallas Chamber of Commerce has been behind for a long time now. We got to make sure that people don't get confused and think that we're all done. We're not done.
Thank you for that answer. And just for the people that aren't in healthcare, when the senator says 90-10, the federal government pays 90 cents, we pay 10 cents, as opposed to the 60 cents and 40 cents. Hey, Chris, let me ask you this. A lot of the people at this conference are healthcare people, healthcare providers, and we appreciate that. But we've really got some great business leaders that maybe don't deal in healthcare every day. So can you talk to them about why they should be concerned about expanding Medicaid and increasing access to healthcare?
You bet. And let me reiterate what the senator was saying earlier, that there are so many pieces of legislation. There have been about 90 plus filed to date dealing with some sort of Medicaid. Senator, your bill, which is a very good piece of legislation, that is a piece of legislation that is going to fix a problem. So many pieces of legislation that are filed are really searching for problems. They don't actually have a problem to fix. This one actually fixes a problem. And so I want to reiterate that all because we got the waiver doesn't mean that this problem is fixed. Not at all. So, Steve, thank you for that question. And really, we talk to and stay very close to large, mid-sized, small businesses all across the entire region. And by really improving the health of our North Texas workers and their families, we cannot forget their families, we really increase the productivity. And that's what is most concerning to our employers. We increase the longevity of employment, pursuits for education, consumer spending, sales, property tax revenue of state and local government. It all depends on the health of our workforce. Everyone wins when we have a more productive and educated workforce. And to have that more productive and educated workforce, they got to be healthy. It is inhibited when we have unaddressed health issues and our employees are unable to work. And we've experienced that, unfortunately, during the pandemic. People are sick. They cannot work. The productivity is down. Lack of revenue is down. Goals are not being met. And so we must, in the future, make sure that we have more people working who are healthy. One of our, as I mentioned earlier, one of our biggest assets of our region is a highly skilled, educated workforce. And in a family, even if one member of that family has any sort of unaddressed health issues, the pathway for other family members toward education and to further employment is all impacted. So bottom line is keeping North Texans healthy is certainly important for our employers. And that's why you're going to see more than just healthcare providers, but general business leadership. Once it's all said and done, mid-March comes, we work through all of the pieces of legislation that are filed. I really believe you'll see general business leaders get behind this particular issue. They already are in a lot of ways, but I think you're going to begin to see them sign on more that we must fix this issue. And there is no better time right now in our region, in our state, than now to do that during the 87th session.
Right. You know, Senator Johnson, we've been trying for years to get Medicaid expanded. So let me just cut to the chase. The Speaker recently said, we don't have the votes to pass Medicaid expansion in Texas. However, we will work on a Texas solution. Now, I know you've introduced Senate Bill 117, and you also have introduced Live Well Texas program. Is that the Texas solution he's referring to?
I hope it is, Steve. My meeting with I've already been talking with the speaker's staff, and we'll be meeting very soon. But Senate Bill 117 is the Live Well Texas program, and it is what's being offered as a Texas solution. We have never had an attempt to expand Medicaid under the Affordable Care Act through the alternative route of an 1115 waiver. And it's that waiver from normal Medicaid expansion requirements that allows us to not just say that we're crafting a Texas solution, but actually craft a Texas solution that utilizes our MCO structure, that utilizes our system of charitable institutions as network partners, that utilizes our Texas Workforce Commission and helping people transition from state-supported health insurance to private health insurance. These are the kinds of things that allow us to kind of cast aside the partisan differences. Oh, I don't like Medicaid expansion. You're giving away free health care. But what if we're creating a health savings account and we're incentivizing people to make good decisions about their health, involving them in the process, promoting individual agency? And it's another way that it's distinguished from the non-expansion waiver we're talking about, where if that was really our solution to the uninsured problem, we would say that uninsured people have no stake in their own health care. They're supposed to sit around and get sicker and sicker and sicker and then go to the emergency room. Not a good model from any political perspective. But a good model, favoring Texas independence and self-sufficiency, is a plan that gives people access to health care and engages them in the process and still draws down those $90-10. And so there's polling going on in conservative areas, and even the phrase Medicaid expansion is doing quite well. But aside from that, the conservative members, particularly from rural areas, know that we need to do this. They absolutely need to do this to stabilize their health systems and to help their constituents. They just need to find a way to do it that doesn't look like they're capitulating to the federal government. Even that, I think, is way overplayed. I think people are more afraid of it in the legislature than they are outside of the legislature. But I happen to be in the legislature, so we're going to deal with it on those terms. It is the Texas solution, and it should, if it passes, look different than the form that I filed it in. Absolutely, because we need input from everybody, not just stakeholders, every legislator, all their constituents. So nobody files a gigantic comprehensive program with the expectation that it ends. It's not the Texas solution, but it's a great blueprint for it. It's a great starting point. So I'm really looking forward, and I can tell everybody on the call, I've had very encouraging conversations with virtually everybody I've talked to in both parties. They just need to find a way to get it done politically. And that's why it's so important that we not lose sight of it in this moment, that we're not blinded by the renewal of the old waiver. It doesn't address the problem. We need a Texas solution to address the problem.
Thank you. You know, Chris, we've been trying to expand Medicaid ever since the Affordable Care Act passed. And, you know, sometimes I hear from people in the legislature, well, Steve, you're somewhat conflicted. You're a provider, you represent providers, and you're going to get additional reimbursement. And, you know, that's a valid complaint they could throw back. So what I want to ask you is this: to look at facts and figures and to look at some of the economic impact. I know Ray Perryman, who's very well respected out of Waco, has once again done an economic impact of looking at Medicaid expansion. And I know you are a student of reading those kind of reports. Can you share with the people in this conference some of Ray Perryman's findings?
Yeah, you bet. Dr. Perriman's study was very extensive, and maybe a missing link to this extent that we haven't had in the past when we've had this discussion is extensive economic impact data. How does it really impact state and local governments? Recapturing our dollars, what does that mean to the state? And having a whole team of economists look at that. Well, we've done that now in Texas, and thanks to one economist, Dr. Ray Perryman. So let me dive into some of his findings. They estimate that with Medicaid expansion, the state of Texas would have a net gain of $2.5 billion during the 22 and 23 biennium. And that's the state, and local governments would have a gain of $2 billion. So he also estimates that in addition, the state of Texas would see a gain of $45.3 billion in gross product and a gain of over 460,000 job years of employment. So he is diving into a lot of details on the economic side of recapturing our federal dollars back to Texas.
Hey, Chris.
Yeah,
Chris. From a legislative perspective, I want to emphasize what you just said about those numbers: the $2.5 billion in state revenue, the $2 billion in local revenue. Because Steve, when we were talking about, is this a Texas solution? Is this the moment when we can do it? When we're looking at the economics, and Chris is 100% correct, we should be looking at the economics. What he just said was it makes $2.5 billion in the first biennium, net positive revenue. After we take state dollars and pay for people to have health insurance, we still have a net benefit of $2.5 billion. So when somebody says we can't afford it, they're not looking at the math. We make money off this. Sound too good to be true? We can talk about it later. Chris, I'm sorry to interrupt. I just want people to understand the significance of this. This is revenue generating without a tax.
And just to build on that, what some are saying that they're concerned about is the required outlay that the state would be required to make. How much is it going to cost us? So Dr. Perriman's research estimates that for every $1 invested, the state of Texas would receive $1.95 in tax revenue. So again, we're investing to make even more, to the senator's point. Thank you for that question, Steve.
Yeah, and I think it's important that business people get involved, because the business community, I can tell you, the governmental officials in Austin listen to the business community. They really do. I'm gonna pivot just a little bit, Senator Johnson. We heard a great presentation earlier by our keynote speaker, and he touched on the Biden administration. This waiver that you and I are talking about, the non-expansion waiver that got renewed, was actually renewed through Seema Verma, who worked for President Trump. So now that the Biden administration is in and they're looking at some of these waivers that are approved, how do you kind of gauge that? Do you think we're at risk in any way?
I do. And at best, I would call the non-expansion extension uncertain. It's been granted. And again, it doesn't solve the problem of uninsurance. It gives us a backstop. And we may not even have that backstop. What happened is Texas brought the request for that extension pretty late in the game and asked for fast track consideration. And fast track consideration was made and it was granted, all very hastily. Now, CMS itself has regulations about what can be fast tracked and what can't. And this basically can't be fast tracked. They did it anyway. Maybe no one will notice, maybe no one will care, and maybe it stands. But I think it's absolutely a possibility that people are upset with the fact that it was rushed through and that it was done in contravention of CMS's own standards, and that therefore they'll say to Texas, we're not going to reject your application, but start over. And then we're not assured of this backstop. So it's all the more important that while that is uncertain, well, that's kind of hanging in the balance, we move forward aggressively with an expansion, so that because by proceeding with an expansion, we will have fewer uninsured people. We will have a lower burden of uncompensated care. And therefore, the potential loss of that uncompensated care piece is buffered. So it's just another reason that we need to proceed with Medicaid expansion.
Great. I'm going to stop there just a minute because I see a question in the chat box, and I think this came from Stephen Angeletti at the law firm. Let's see, with the legislative session getting kicked off, what are your thoughts on how much momentum Medicaid expansion can get on the ground, kind of at the grassroots level? And I'll throw that out to both of you as to What do you think about grassroots support to really get this through the legislature?
Chris, you want to start? You were talking about the cities and the mayors. It was tremendous.
No, I think the timing is right more than any session that I can remember. With what's going on, given the pandemic, the new administration, yes, we just got a waiver from the previous administration, but again, that doesn't solve the problem. So I think from a grassroots standpoint, that's certainly what we're working on, is to get general business leaders, get residents to talk to their legislator, talk to our 41 House members and 9 senators from our region, let them know that the time is right to have this discussion. And I think we're seeing that across the aisle. We're seeing Republicans and Democrats not just filing pieces of legislation, but we're seeing them say that, yes, the time is right for that discussion.
And I'll tell you that I've probably had meetings one-on-one with 20 Republicans in the House and the Senate. Not one of them slammed the door in my face. They're all very interested. It's politically very difficult because some of this stuff turns on a Republican primary. So it's not so much about the overall momentum. It's can we put some momentum in certain places? The overall momentum is important. And what Chris was saying about the mayors and city councils in North Texas getting behind this, I think could really be the final push that we need if we can make it statewide. And what I like about local government is they don't get as wrapped up in partisan history because there are no Democrat or Republican potholes, garbage trucks, or health departments or police departments. There's just safety and health and good functioning, clean streets. And so they may have the power to come at this in a district that might otherwise not be aware of the benefits, be stuck in some old political ideas. And if we have people at the local government level that are outspoken on the subject, I think it will have a very strong effect on the public at large and their perception of proceeding with a healthcare coverage expansion.
Steve, can I add just one thing?
Sure, go ahead.
Of the 38 states have already done this, many politically look like Texas. And we're continuing our conversations with leaders in those states from the business sector, public and private sector. How did they get it done there? What did their model look like that we could adopt here? And so this can be done. It can be done from a bipartisan standpoint. It's been done in those other states in the same method.
And Steve, that's exactly what I was trying to do with SB 117, the Livable Texas program, is look around the nation, particularly at Republican-led states who have successfully implemented a Medicaid expansion or a ACA coverage expansion. Done. Some of the things that some of them have done have not been such good ideas, like work requirements, because they're repeatedly held unconstitutional. Empirically, they're demonstrated not to work. But what about work referrals? What about job counseling? There may be some on the left who don't really like that. There may be some on the right for whom that's the deal maker for them. So I've put that in SB 117. We do have referrals. They do work with the Texas Workforce Commission and try to cooperate with non-governmental employment counseling services and things like that. We do have things in other Republican states that encourage individual agency in their health, like health savings accounts, like financial incentives to quit smoking or lose weight. It really, if it can be done in these other places, let's find the elements that conservatives like, and then see if they worked. If they don't, let's not do them. But that's the benefit of going last. We've got the experience of all these other states, and so there's a lot of things those states have done that have worked very well, politically and practically. So those are the kind of things we put in there. And then what about the momentum? The more dialogue there is around it, you come to people who might have been resistant to it and say, no, this is not old Medicaid. This is something we're doing. This is our way. And that's exactly what the other states have done. They have gone to the public and said, Medicaid was a broken system. We fixed it. It works for us now. Take a look at this. And no one has gone backwards.
Chris, you did a good job of articulating the states that have expanded Medicaid. How many of them have reversed that decision?
I don't think any have.
Yeah, I don't think so either. I think that in of itself tells you something, which leads me, Senator Johnson, to a question for you. In your Senate Bill 117, suppose, this 90% that the federal government is paying, they stop paying it. What happens?
The whole plan blows up. There's a self-destruct mechanism. We're not stuck with it. And I put that in there mostly because there are people who are genuinely concerned that the federal government may stop that payment. The other reason it's in there is there are a great many people, both inside and outside the legislature, who believe that the Affordable Care Act regarding a coverage expansion, a Medicaid expansion program, phases down, and not just down 100, 90, 80, 70, 60. That's false. It was never the case, but that didn't stop it from being believed. So for those who are still kind of thinking about that, don't worry. The plan goes away if it changes. And the last thing I'll say about this is I don't expect it to change. I feel very confident that if it changes, it's going to go up. There's already talk in the Biden administration and the present Congress to re-incentivize states like Texas to expand Medicaid. They might make the initial match back to 100%. That would really be great. And it would ratchet down all the way down to 90, which is a great, great deal. But the main reason I think it's not going to happen is not just because the Biden administration won and Democrats now control both houses. That's still unstable. There's 4 more years we're going to have an election. But what makes it really, really stable, irrespective of what the Supreme Court does, and I don't think the Supreme Court will invalidate the act, we now have 38 states, as you all have mentioned. There's 223 million people in those states. Their economies are functioning by drawing down dollars at 90-10. It would be a huge mistake for a U.S. Congresswoman or U.S. Congressman to go back to their state and say, guess what? Fewer of you are going to have health coverage, and I've withdrawn a lot of money from our state economy. Not going to run for re-election on that one. And then finally, 53 million people in those 38 states are expansion enrollees, and they receive routine mental health care right now that they didn't used to get. They receive routine primary care instead of driving to the emergency room like they used to. And they show up to work and they take their kids to school and they're functioning better and their family finances are better. It's not going away.
Right. Hey, we got another great question. Thomas Peck sent this in. With the Supreme Court scheduled to hand down the decision regarding the future of the ACA, it should be in the spring. Does that cast uncertainty, and does it weigh on the likelihood of Medicaid expansion in Texas?
It only if we let it. Again, the Supreme Court is not, I don't think they're going to invalidate it. It's not even, I mean, that's just my opinion because I've read the case and I think it's an absurd challenge. But much smarter jurists than me have looked at it, very conservative jurists, and don't think there's any chance the Supreme Court will invalidate it, even if the few of the justices do. The questioning at the oral argument suggested that at least 5 of the Supreme Court justices are going to go deny the attempt to strike down the Affordable Care Act. At worst, what could happen is they could find the provision of the insurance mandate unconstitutional, and that provision is stricken from the act. And if that were to somehow topple the entire act, the Congress is going to fix it. They're going to take one of these things and they're going to draw a line through that mandate and say, here, we're done. It's not going away.
Chris, let me ask you another question. I've been thinking about this. You brought up the point and you talked about Ray Perryman's report, but what are some of the ripple effects of additional benefits that you feel that businesses in North Texas expect if we have Medicaid expansion?
Yeah, you bet. Well, really reducing the number of uninsured would make our area even more attractive. I started out by saying that we are the envy of site selectors and we have all these assets on why companies are moving here. I think we would be even more attractive to corporate relocations and high-skilled workers moving to Texas if our healthcare costs become more of a factor. And you talk to economic developers all across the entire country, and healthcare costs are being part of the criteria that companies are looking at when they relocate or when they expand or even retaining companies in the state. So when families are considering to be moving here, this particular issue is going to become an issue if we don't come up with that technical solution. And, you know, I really do believe that most of our legislators, if not the majority in Texas, believe that there must be improvement to Medicaid. And I believe most believe that it's possible in the 87th session. Just what is that, as the senator referred to, what is that Texas solution? What does that look like? And to what extent are we willing to go in the next session?
And Steve, can I jump in? Is that okay?
Yeah, absolutely.
On that subject of a Texas solution, I want to largely what I want the people to do is have a filter on as the dialogue continues. You may hear people say the Texas solution means it's got to be really targeted. We're going to make sure it's people who really do need Medicaid. Now, a Medicaid expansion or an ACA coverage drawdown deals with people who are living in poverty. How much narrower do we need that group of people to be? That's pretty narrow. The other problem with narrower solutions is they draw money down at 60-40. And the magic math that we've been talking about, Perryman's numbers, and three other economists have reviewed this. Everybody agrees this is a really good deal. Depend on the 90-10 match. There's nothing out there other than an ACA expansion that draws down 90-10. So as far as I'm concerned, the Texas solution is something we craft, but it's got to be 90-10. And it's the buzz line needs to be 90-10 or failure. Those are the two options. You do it 60-40, it's either going to be so small, it's going to be a sad excuse for addressing the problem, or if it's on any kind of scale at all, it's going to have a huge negative fiscal note, which in Texas legislature means it ain't going to pass. It's going to cost us money instead of make us money. There's not an alternative to an ACA expansion. There's alternatives about how we do it.
I'm going to close out with the final question and then turn it over to Ken Malcolmson. And this is an unfair question, Senator, but I mean, you're ready to handle those. You brought up something very important. You're working very conscientiously to expand Medicaid. So let's assume you're successful, and we hope you are, and we expand Medicaid. We still are going to have 4 million people, or at least 3.5 million people in the state of Texas with no insurance. So pretend like you get Medicaid expansion done. What can we then do to help the additional 3.5 million people?
It is a great and difficult question. 2 million of those people are undocumented immigrants. And managing that is going to require a great deal of work with the federal government. A lot of that's going to be at the federal level. Politically and practically, that's going to be hard to do, a whole lot to address at the state level, certainly for the immediate term. 2 million more people are either underinsured or uninsured by choice or because they simply can't afford it. Now, we can talk people into it, but health insurance is staggeringly expensive. So while expansion picks up people up to 138% of the federal poverty level, what if you're 200% of the federal poverty level? What if you're a family of four making $45,000 a year? Health insurance might cost you $20,000 a year. So we can find ways to bring down the cost of private pay health insurance. One of the things that we're looking at, and that I've tried to do last session, we'll try again this session, is what's called the high-risk reinsurance pool. And that takes the riskiest, most expensive people and puts them in one pool, and the state reinsures that. Now, if you're a private carrier contracting with the state to take care of the population, or a private carrier just playing in the private marketplace here, and your risk is lowered, it's more attractive. So in states that have done this, what they have seen is additional insurers come into the marketplace, compete, and prices go down. That's what we want to do. We want to lower prices. Meanwhile, the healthcare system itself is in rapid transformation in many different ways, and we're hopeful and aiming and trying to be a partner with the private sector in developing less expensive forms of care and ways to take care of people earlier in the process before their care becomes acute and expensive. Overall, lower costs, that'll make it easier for people to purchase private insurance.
I want to thank both of you. Excellent job. You absolutely brought out great points. And, you know, it is a grassroots effort, and we've got to all work together. But hopefully we'll continue to impress on people the need to expand coverage and help reduce the uninsured. And now here's the leader of the pack, Ken's back.
Yes, well, thank you, Steve. And I would just want to thank this very esteemed panel today and for all of your service to the community. Senator Johnson has become, from our perspective, the go-to expert on this topic and the topic of reducing the uninsured in Texas. And he's done that in a relatively short period of time during his short tenure as a state senator here in Texas. So we can't thank him enough. Can't thank him enough for his partnership with the North Dallas Chamber of Commerce as well. Chris Wallace has been one of our greatest collaborators on so many different things, and he mentioned the Regional Chamber Coalition. We're so proud to be part of that. And as he mentioned, this is one of our top legislative priorities for this particular legislative session. And then last but not least, at the annual installation and awards dinner put on last night by the Dallas County Medical Society, Steve Love was recognized as the Millard and Robert Heath award winner last night for distinguished service by a non-physician in the community. Could there have been anyone more worthy of that award than Steve Love? And Steve, we can't thank you enough for your partnership and everything you do in collaboration with the North Dallas Chamber of Commerce. A few thank yous before we close out the conference today. I want to thank this panel and all of our speakers today. They've all done a superb job of delivering great content to us. And in recognition of all of our speakers, we'll be making a donation in their names, a very small token of our appreciation, to the North Texas Food Bank at the conclusion of our fiscal year here at the end of the month. We also want to thank all of our sponsors today. Let me just run through them real quickly again. Bank of America, Baylor Scott & White, BKD, Blue Cross and Blue Shield of Texas, Children's Health, HDR, J.E. Dunn Construction, Medical City Children's Hospital, Methodist Hospital for Surgery, Polsinelli, Texas Scottish Rite for Children, and UT Southwestern. Our silver sponsor was Parker University. Our media sponsor, Dallas Business Journal. Our supporting sponsors, the Dallas-Fort Worth Hospital Council, the Health Industry Council Foundation, Team Logic IT, and the Chrisman Company. And we can't thank you all enough for allowing this program to continue to occur even in the virtual setting. And obviously, we're looking forward to being in person again next year. I also want to thank our healthcare conference planning team. We had a great contributions from a large number of people representing most of our sponsors, but I particularly want to point out the contributions made by Dr. Mark Neve, Stephen Angelette, Sharon McClure, Shristi Shrestha, and Steve Love. They've always been great supporters of our efforts to put together a first-class conference like today's. And of course, a conference like this is not successful unless we have engagement. And 275 people registered for this event. And we can't thank you enough for your interest and your participation in these kinds of events.